picking up from where Sean left off, really, and putting some local context around what he was saying. Just to pick up the point about mental health drugs, because I think it's important to say, I work as an inpatient consultant at Torbay with older people with functional illnesses, so my patients are usually profoundly depressed, profoundly psychotic, some of them at death's door, and we would not get them better without the help of medication. And my drug budget is under £4,000, so that I don't use particularly expensive drugs. 2/3 of those are for physical medications as well. So our drugs actually, what costs £1 million a year to run, are a minuscule proportion of what we do in our budget. Use other treatments as well, of course. So this is what I'm going to very quickly do. So put a bit of national context around the local issues, quick look at the evidence, pick up the local context, some drivers to improvement, and next step. Okay. First thing is, our services are designed around the National Service Framework, which came out in 1999, so it's 13, 14 years old now, and it's based on research, up to 20 years old. It's getting a bit long in the tooth, and actually what we know is that shape of our services is causing all sorts of problems. Causes problems to us, causes problems to you. Silos, different teams, tiny little teams, and I'll pick up on that in a minute. No Health Without Mental Health came out in 2011. And we have a quick plan which picks up a lot of it. And this, again, picks up some of the things that Sean was saying about actually bringing mental health into the mainstream. And mental health being part of the local healthcare system, real part of the healthcare system. So supporting acute care pathways, that goes back to liaison. Out of area care, bringing people back in. Talked about secure beds. Do you know where the nearest female secure beds are? Bristol. And I think there are 12 beds this side of a line drawn between Liverpool and Southampton. So if you're female and you've got a forensic history, the likelihood is you're going to be right over the other side of the country. So actually, if we're going to make care pathways work, we need more local beds, and we need to get the pathway working locally. Physical health and comorbidity we've just talked about in terms of the longevity of people with severe mental health problems. We need to improve productivity. That's a major issue for us. We have this fantastic electronic record. It's brilliant. It's actually brilliant. It's improved our care no end, but actually it takes twice as long to do anything now. It's a real problem for us, and we need to solve that. So we spend most of our time now in front of computers, not with patients, or doing things that would help integrate care.
I think that's like the rest of us.
Absolutely, yeah. I'm glad it's not just us. That's reassuring. Care in the most appropriate place I sort of touched on in terms of care out of area, but also, there's no bed like your own bed, so actually helping people to stay in the right place, not migrating towards hospital. And then, as Sean was touching on, personalisation experience, bringing the person's own perspective into their care and treatment. Interestingly, one of the things we've been talking about locally more and more is alternatives to inpatient care. What can we do that is better than what we're providing now? There's a real national problem around inpatient care in this country. It's perceived as very custodial, and people's experiences are awful, frankly. And there's a very good Mind report on this that came out a couple of years ago, last year I think it was. And there are really good examples around the world of person-centred, personalised, recovery-orientated services where they're using different ways of supporting people in crisis, and I'll touch on that in a minute. And then, yes, it's up there. 2011 it came out, the Mind report. So a bit of the local picture. Now this is from the Public Health Observatory, and it's available if you just do a web search. And this is the figures for Devon and Torbay. The top graph, I know it's difficult for you to see, is the numbers of people admitted for self-harm. And you can see that Torbay, this is the whole country, Torbay comes out rather high in the numbers of people who end up being admitted for self-harm. Devon, and this is the whole of Devon, not just South Devon, is also in the top half of the graph. So that's for adults, that's for children. We're not particularly good for children either. And this is a big issue if you look at the whole sort of health and social care picture. These people have a considerable amount of morbidity. A lot of them go on to kill themselves. And, you know, it should be a worry for us that we have this picture in Torbay and South Devon. This is our suicide rate, which is a better picture, but I think it's probably by chance rather than by design, although some of you may have different views. We used to be here, second in the country. We're now down in the middle, but these are small numbers. We're only talking about 10, 15 patients. So we may go up and down this graph depending on local circumstances and individuals. Talking about liaison services, what we know is that demand coming through A&E, and it reflects the previous graph, is increasing. And often people who present with self-harm who aren't admitted are referred to our crisis team, and what we know is that there's an increasing demand. If you have trouble getting
that graph like that, you can't, you surely, where you've got nothing on the left-hand side, you've got to stop, you know, you're going like this, that you've got too many, you know, that line you've drawn.
This line? Yeah, so that this is a moving average. Yeah.
So, but regressing it back there then gives you the wrong impression. Actually, it's probably flatter that. And
it's going up.
Yeah, but it's not like this, is it?
No. Okay. Point taken. Sorry. But it's going up.
Yeah.
That is a phenomenal increase in demand, whatever's happening. There's a problem here, I would suggest. And we know that there's a problem with crisis teams. You're going to pick up that point later. My point is we need to look at where the demand is starting to build up and have a think about what we're going to do about it. Crisis team caseloads are increasing. This is referrals. This is the number of assessments. This is the caseload. Our crisis teams have to do a range of things. They have to gatekeep our ward, so they're seeing people that our own teams are referring to them. They're having to assess GP referrals, and they're having to home treat as well. So they have a broad remit, but they have a very important remit. And if we're talking about personalised care and trying to keep people in the place they want to be, which is at home, then we need a crisis team that's able to function to do that. So
what? On that one as well, why isn't the assessment the same as the referral?
Because they don't assess everyone that's referred. So they have to make a judgment. And I'll come to why that is now. So this is our shape of our front-end systems for urgent care. So here we have hospital systems, community systems. So we've got a hospital liaison team, which we were talking about. And you notice this is 5 o'clock, so we've got traditional services running 9 to 5. Hospital liaison, the inpatient medical team I put in there, Torbay CRHT, and Team Bridge and South Hams. And what you can see is what we've got is a heavily weighted system to 9 to 5. So it's no surprise that as soon as you get to 5 o'clock, there's a problem within the system. And of course, you lot don't work till 5. You work beyond that. And if you've got a problem, then you're trying to access services which are a bit threadbare. So the balance of the service is wrong. I'm not stood here saying we need more, just saying we need to have a think about how this is set up. We know that liaison services, the demand doesn't go from 9 to 5, it goes from 1 to 9 to 11. So we need to stretch our hospital liaison services to a different shape. One of the other issues we have in the southwest of Devon is the number of percentage of adults with dementia were incredibly high, both Torbay and Devon. And there's an awful lot of work that's been happening around this, and I think we're way ahead in some respects in dementia care in terms of how we think about how we integrate care. Pretty good on residential home admissions in South Devon, and also hospital admissions. We're not bad on that at all.
But with dementia as a diagnosis, or the primary diagnosis, or
Primary diagnosis.
Primary diagnosis.
Yeah. Psychiatric intensive care. So another part of our urgent care system. We don't have psychiatric intensive care within Devon, so people have to go outside of Devon, and I think this is something we need to think through. Is this the right thing to do? The question is, should we be having people going out of area? We know that if people go out of area, their length of stay are longer, and also there's a flow to low secure, which is expensive. And we get into the secure system, and then it's difficult to get out. So we need to have a think about how we're managing our psychiatric intensive care. We've done well, and we manage an awful lot more people on our wards, and we've staffed up our wards to do that. We then get criticised by Monitor for our bed staffing ratio being too high. So, you can't win. But I think, trying to keep people on our own wards in crisis is the thing to do.
Can I just ask what you mean by psychiatric?
Yeah, so
Sort of patients who-
very high staffed with patients who are extremely challenging, usually quite aggressive or at high risk of self-harm. So very high staff. So you may have a 1-to-1 or 2-to-1 with a patient. So treating the acute episode and then stepping down to a normal acute ward.
What's that ratio away from here then? Is the staffing ratio the same away?
No, it's much higher. And
Higher still?
Yeah, it's much higher than our acute
Criticising you
wards.
then?
Sorry?
How are they criticising you?
Because our wards have more nurses per bed than the national average.
But if you're looking after these patients,
Oh, that's our argument.
yeah.
Yeah, so we're keeping more people at home, but nevertheless we've got, on average, about 8 to 12 patients out at any one time out of Devon. Talking about personalisation, our test is, one of our tests, and we survey 1,000 patients a month, is are our services good enough for your family or our family? And we're not bad, but we could be better, I think. And some of the reasons why that is, and Andy will pick up on that in a minute, I'm sure. So around 80% of people think our services are good enough for my family. In the adult services, around 90-95 in older adults, which is good. Our specialist services, things like drug services, Joe from the perinatal service, gender dysphoria services are not bad, and secure is a bit of an odd graph for various reasons. We used to have the prison in there, and prisoners don't tend to like the services that are provided to them. I don't think this data is sophisticated enough. I think we need exit data to get really good quality data rather than a postal questionnaire, because you get a very selective sample. But nevertheless, we know we're doing reasonably well, but there's gaps and we need to do better. So what are our drivers to improvement? What are the things that we're starting to talk about and think about? Well, I've mentioned care as close to home as possible, getting our pathways locally rather than having people flowing out of the county and trying to get them back in. Closer working arrangements. This is a no-brainer really. We need to work more closely with acute care and primary care. And one of the things you're going to pick up on is having linked workers into GP practices. We need to get smarter at that, I think. I think there's still too much of a distance between primary care and psychiatric services. We've lost the links that we used to have. We need to reliably apply the best evidence. And there is good evidence in psychiatry and in mental health. We don't always provide the best care, and we need to be smarter at providing evidence-based care pathways. What you often find in mental health is, depending on which worker assesses somebody, medical, psychology or nursing, you may get a different style of intervention, not necessarily the best evidence intervention. We talked about productivity. We do a huge amount of low-value work for various reasons, often for regulatory reasons. It adds nothing to patient care. And what we need to do is focus more on high-value care and have agreements around that and support, for instance, from the commissioners around that. Reliability of services, especially when things are getting urgent. The last thing you need as a GP is to be sat in surgery with somebody in crisis and the crisis team saying, we haven't got the capacity to see them. We need to think about how we sort that out. Supporting acute hospital services, we talked about liaison services. Co-production, one of the things we've been talking about is how we reshape our mental health services, not primarily from our point of view, but actually the people using it, their supporters, social care, third sector organisations, primary care, and having a conversation about what we need to do. We've been guilty in the past of a very top-down reorganisation. The NSF drove that. There was good reasons to do that, and actually I believe there was a massive step in the quality of mental health services in the late 90s, but we need to move now to one where we're shaping the services according to local need. And we obviously need to make services sustainable. We're not going to get any more money. So examples of things we might want to think about. I've talked about alternatives to admission. There's good evidence around peer support. You mentioned it, Sean. There's a peer support service up in Leeds. Instead of pitching up a casualty up to 2 o'clock in the morning, you can go and talk to people who know what it's like to be in crisis and get some help from them, supported by a crisis team. Crisis houses step down. They're cheaper. People stay less time in them, and they prefer them to institutional care and to acute hospital wards. Talked about recovery colleges, recovery academies. We need to, and this is something you've been doing in primary care with people with physical problems, identify people at high risk of being readmitted. 13%, it's a national figure, same locally, of people are readmitted once they've been discharged within the next year. So we have a high readmission rate. We know who those people are, and maybe we ought to be targeting some more resource around them. Talked about practice link staff. 7-day extended working. You know, our liaison services run Monday to Friday, 9 to 5. That ain't going to work, essentially. Health and safety review. Our crisis team go out and see people in pairs. If you're going to see somebody who's 80 in pairs, why is that? Why is that? That's our policy, but we need to start looking at how we use our resources better. Merging our ward and crisis teams. What you find is ward staff have been there for donkey's years and don't understand necessarily when people are ready to go and managing that risk. So actually, if you combine the crisis and ward staff, you get a better understanding of when people are ready to go out of hospital and they stay less time in hospital. And there are examples of this. Somerset do this, for example. And there's various other things we can do, and where I'd better be moving on. So in conclusion, we're aware that nationally and locally demand is rising, will continue to do so, but resource will shrink. There's no doubt about it. We're on flat cash. Inflation means that we have to reduce resource. We're trying not to reduce clinical resource, but that's the reality. We need to consider how to use that resource most efficiently and effectively. And we need to do a whole system redesign to do that, but do it in a way of co-production. And we need to align mental health better with mainstream services and be part of mainstream services and embedded in mainstream services. I'm going to give you an example. The liaison service does not work closely with a health psychology service within Torbay Hospital. Why is that? It's just nonsense. It's balmy, isn't it? We need to sort those sort of things out.
It's on the list.
It's on the list. We need to talk better to each other. And talking about things like medically unexplained symptoms, there's some fantastic data around medically unexplained symptoms. Around 50% of people attending outpatient appointments don't have a physical pathology. I just find that's just staggering, isn't it? 60% in cardiology outpatient clinics. And yet we haven't got mental health input or psychology input into those areas. So I think there's a lot we can do, and we've got a big long list of things to do, which I think you'll be coming to now.
Thank you very much, David. Perhaps we could leave questions because we're running a